Hello, everybody, and welcome to this second webinar, which we're going to be focusing on gaze stabilization tests in VNG. And earlier this year, we had Dr. Barine come and do the first part of this webinar, which looked at gaze stability with fixation. And today we're going to look at gaze stability without fixation. And we're really lucky to invite Dr. Barine back to participate and host this webinar for us. So just a few housekeeping issues before we begin. If you have any questions as Dr. Barine goes through the webinar, then please do write those questions in the instant messaging box, and I will ask those in the question and answers forum at the end of the webinar. So without further ado, let's get this show on the road. And for those of you who are not familiar with Dr. Barine's work, I would just like to introduce him. So Dr. Barine actually received his master's and doctorate degrees in electrical and biomedical engineering from the Ohio State University. He then continued to establish and then serve as the director of Balance Disorders Clinic at Ohio State, and did so for 25 years. And during that time, he's published over 80 articles and book chapters and taught on numerous national and international courses and seminars. So it's my pleasure to welcome Dr. Barine to the stage, and we're really excited to hear what you've got to tell us today.
Thank you, Lee. I hope everyone can hear me. If not, I'm sure Lee would let me know. Hello, everyone. Welcome back. It's my pleasure to talk about the gaze stabilization test in VNG, the second part, the gaze stability without fixation. Now, this may not sound as exciting topic as one might hope, but in fact, in almost the majority of the tests that we do in the clinic, we encounter some form of nystagmus, and especially the type of nystagmus that I'm going to talk about today. So understanding the origin of this nystagmus and also how it affects the rest of the test is important. So for those of you who may not have listened to the first part of this webinar, I'd like to just quickly review, spend the first 2 or 3 minutes review what we've talked about before. So basically, most normal individuals can maintain a gaze stability either with or without vision and in the absence of vestibular stimuli. So when you cannot maintain gaze stability, it usually manifests itself as nystagmus, various forms of nystagmus. So in the VNG test, we examine this ability to see if the patient can maintain a gaze stability. But we do it in different conditions. When we look at the gaze in off-center positions, that's what we do in the gaze test. When we look at the nystagmus in the center gaze, with and without fixation, we refer to it as a spontaneous nystagmus test. And finally, when we look at the static position testing, when we look at the gaze stability and presence of nystagmus in different head positions. So again, I just want to emphasize in this topic we're talking about static position test, or what's commonly referred to as positional nystagmus, rather than positioning nystagmus, when the nystagmus appears when the head is moved from one position to another. So in this webinar, in the first part of it, we talked about how to perform the test correctly, and then how to interpret the clinical significance of that. And again, this particular session is on gaze stability finding without fixation. So again, this is just what you may have seen in the previous webinar. This is the pathways that are involved when you have your testing for gaze stability with fixation. So that most of the pathways are central pathways. So you have here the peripheral vestibular system that involves the labyrinth and the vestibular nerve. Then the information goes to the vestibular nuclei, and then from there on, it moves higher up to the central nervous system and basically controls the eye muscles to maintain gaze stability. So when we're testing the patient with fixation, almost all of the pathways that are involved are central pathways. So generally, as we've talked about before, any test finding that you see exclusively with fixation, generally that's not a peripheral sign, that's a central finding. When you remove fixation, in other words, close the goggles or close the eyes, in this case now the entire pathways are included in this type of almost all of the pathways. That includes both peripheral and central pathways. So for the most part, gaze stabilization tests that we do today, we're going to talk about today, meaning the tests without fixation, generally they're non-localizing. They do not tell you where the problem is coming, whether it's a peripheral or central. There are sometimes signs that you could figure out whether it's if it's for example supporting something in the caloric testing and so forth, then you can attribute it to the peripheral findings. But generally, when you're looking at it in isolation, the tests without fixations do not tell you whether it's a peripheral or central. Just one more addition: whenever you do the testings without fixation, you have to alert the patient. And most of you know why this is done, but if somebody is unsure about that, I'll be happy to talk about it during the question and answer session. And exactly what would be the better alerting techniques, I'll be happy to discuss that. So, so in part one, we talked about the gaze test. In the second part today, I'm mostly going to talk about the spontaneous nystagmus test. Basically, the procedure for spontaneous nystagmus test is that you record the eye movements in center gaze, in the primary gaze position. You do this with fixation for a period of time, and then you do it without fixation. And again, anytime you do it without fixation, you should be alerting the patient. In each of these conditions, there's a minimum of 20 seconds or so that you should record, but a lot of times it may require longer than that. Once you are able to make a determination, then you can stop. But there's no minimum time, there's no maximum time that you have to be doing this. So I will let it run until I figure out, okay, I know what I'm seeing. Generally, this test is performed in the sitting position, but you can do it in the supine position too. Now, the test that's related to spontaneous nystagmus test, which is the static position test, you record the eye movements with and without fixation while you put the patient in multiple static head positions, which I'll go over which ones we do. Generally, though, most laboratories do not use the fixation part of this test. Some do, and if you're doing it, that's fine. Those of you who are just using without fixation, that's fine too, because most of the information with fixation you can derive from the gaze test. So it's okay just to do the position testing without fixation. And again, anytime we're doing without fixation, we alert the patient. Again, in each head position, the minimum time should be about 20 seconds or so, but again, there is no maximum time. You can record as long as necessary until you can make a definitive decision. So, what head positions do we use? And for obviously, as I said, most of the tests for spontaneous nystagmus is performed in the sitting position. The three primary positions that we include for static position testing would be in the supine position, as you can see in this figure, with the patient in a supine position. Now I'm going to talk about whether we do this with the head elevated. In other words, we do this with the caloric test position, or whether we should do it flat. The two other, I'll discuss that in a minute. The two other positions that we do from the same area with the head turned right, right ear down, or the head turned left with the left ear down. For those of you who are in the United States, the CPT code for position testing specifies that you have to do it in 4 position. So if you're doing the minimalistic test, which is what I have in this figure, you include sitting position as a part of your position testing as well. So this would be the 4 minimum number of head positions that you will do for the position testing. Now, some laboratories include other tests, such as other positions, such as head hanging. That's fine. That's not, in some cases, it might give you some information, but typically this minimal set should be enough for most tests. If the patient complains about a specific head position, then I usually include that head position in the battery of the tests. Now, I'm going to discuss in the supine position or in the head right, head left, left ear down or right ear down, whether we should do this, whether the patient is completely flat or the patient's head should be elevated 30 degrees. There's no research that shows one is different than that, so whichever one you're doing is fine. I personally prefer the caloric test position to a completely flat position for several reasons. One is that as soon as you're finished with the position testing, then you can move on to the caloric test without moving the patient. The second reason, which might be a little bit more important reason why to do it in this particular, in the caloric position, is that basically position testing is to look at the orientation, to look at the effect of head position or gravity orientation with respect to different canals. And when you're completely flat, none of the semicircular canals are in the plane of gravity. In the supine position with head elevated 30 degrees, at least the lateral canals are in the plane of gravity. So that's why I prefer this method. And then for a convenience point of view, I can actually do a roll test as I am doing the position test. So from the supine position, instead of having the patient turn their head right or left, I'll just tell them, I'm going to move your head. So I just do a quick turn of the head to the right, and if there's any transient nystagmus, which could be caused by lateral canal BPPV, I will note that. So I will not generate that unintentionally when the patient is moving right or left. I will intentionally include the roll test in my static position testing. Obviously, if there's nystagmus, you wait until it ends, and then if you're recording the video, it's important to keep that, and also now perform it to the other side, to the head left ear down. So, but again, if you prefer to do it with completely flat, that's okay. There's no research that shows any difference in these two methods. Now, many laboratories include body right, body left. If you're doing it, that's fine. But in most cases, it doesn't give you much, it doesn't give you additional information. So I reserve body right, body left position for specific conditions. If you have no nystagmus in the supine position or sitting position, and you generate nystagmus when the head is turned right or left, that's when I include body right, body left as additional positions. The reason for that is you're trying to find out the nystagmus that you have generated when the head is turned right or left. Is it coming from a neck position or is it coming from the head position? And that's a very important question to ask. So if you have nystagmus in the sitting position or in the supine position, you know that that nystagmus is present already, so you really are not getting any more information by moving the head right or left. So I will just do this only if the nystagmus was not present in any other head position and you generated it when the head was turned right or left. So how do I distinguish between a neck effect and a head position effect? I will have a slide to show you this later on, but generally this is the rule. If there's a neck effect, the nystagmus present, this nystagmus will be present when the head is turned, but it will disappear when the body is turned. That's a very significant finding. That means there's something going on in the neck orientation, such as impinging the nerve or blocking the some artery like vertebral artery. So when the head is turned, you have that nystagmus, but when the body is turned, then the nystagmus disappears. It is the neck orientation. So the way to report that would be exactly what I just said. Just say nystagmus was present in the right ear down and disappeared with the body turned right. This means that the nystagmus is caused by the neck orientation, so there's a neck effect. Generally, that means the patient will receive some sort of CT scan or something to verify whether there's something going on in the neck area. So that's basically why you might do body right, body left. Again, some of you who do this routinely, that's fine. You're not missing anything, but time is always an important thing in VNG nowadays, especially since the reimbursements are so low, so you just want to do this as quickly as possible. All right, so a normal result for a spontaneous nystagmus test would be that the patient will have essentially no eye movement of any kind with fixation, but then you may have some mild nystagmus. Again, we'll talk about exactly what the limit of that nystagmus will be. You may see some nystagmus when the fixation is removed. That will be the same in positional nystagmus or spontaneous nystagmus. Healthy individuals usually do not have any type of significant nystagmus with or without fixation. So basically, what I'm going to talk about the rest of this presentation is the manifestations of spontaneous nystagmus. The most common type of nystagmus you run into without fixation is spontaneous nystagmus. This is also referred to as vestibular nystagmus because it's assumed that it comes from a vestibular asymmetry. It is true, but I want to caution you when we talk about vestibular nystagmus, that doesn't necessarily mean peripheral. Most of the spontaneous nystagmus, the majority of spontaneous nystagmus, it comes from peripheral sources, meaning either the semicircular canals or the vestibular nerve. But there are times that the secondary vestibular neurons in the vestibular nuclei, they act just like the primary vestibular neurons in the vestibular nerve, and if you have any asymmetries in that pathway, you might get nystagmus, spontaneous nystagmus. So the majority of these are peripheral, but you cannot exclude central causes just based on the nystagmus itself. So again, I just want to emphasize that in this topic today, we're not going to talk about the transient type of nystagmus that's evoked when you move the head from one position to another position. So the definition of a spontaneous nystagmus is a nystagmus that's present in the absence of visual vestibular stimuli. When you define it that way, it just seems like spontaneous nystagmus should be present in the absence of visual stimulation. Then the question comes up, why do we do this with fixation? What's the significance of looking for spontaneous nystagmus with and without fixation? The answer to that question is that we do it with fixation to separate that from other types of nystagmus. Again, the definition says spontaneous nystagmus is present in the absence of visual stimulation, meaning having a target for them to look at. So you do it without fixation to verify that, but then you do it with fixation to make sure that that's actually the nystagmus. If it disappears or it's significantly reduced in intensity, it verifies that it is a form of spontaneous nystagmus. Without that, you cannot make that claim. So here's a quick chart to show you both interpretation and also the procedure to go through when we're interpreting spontaneous nystagmus. The first question to ask is the nystagmus present with fixation? Only. No, if you remove fixation, either it goes away or it stays the same. In this case, this is always abnormal. You do not have to have any measurement of any type. When you see nystagmus that's present with fixation only, it's always abnormal. No slow phase velocity, nothing else. It's always central. So if you have nystagmus that's present without fixation only, that's a form of a spontaneous nystagmus, and it has to be higher than a certain limit before it's considered abnormal. I'm going to address why that is. Why is it that we consider low-level nystagmus not significant? And I'm going to give you the numbers here, but I will discuss the why it is why we use these numbers a little bit later on. So for horizontal nystagmus, for VNG, we usually use a limit of 4 degrees per second. Older publications that were based on ENG use the limit of 6 degrees per second. Very few people do ENGs nowadays, but if I were doing ENGs, I would go back and use 4 degrees per second. Most of these were very old studies that are that I think some of the equipment may have not been as sophisticated as we have now. Vertical nystagmus, very few studies have been done on vertical nystagmus. I use a number 7 degrees per second, and I'll justify that later on, but I think we need more studies in this. The 7 degrees per second seems to be a high number, but again, we'll come back and explain where this number is coming from. In almost all of these types of nystagmus, in isolation, they should be considered non-localizing. When you have other information, that might give you more localizing information. So the last item here would be, this is the one that is a little bit more complicated and people might have a little bit difficulty with it, is that nystagmus that's present both with and without fixation. Then it's actually really not that complicated. What you have to do is figure out whether that nystagmus relates to the one of the first two nystagmus types that I discussed. So in this case, you do need to measure the slow phase velocity of the nystagmus. If this slow phase velocity increases significantly, what is that significant level? If the intensity of it, or the slow phase velocity of it, increases by a factor of 2, then you consider this a nystagmus that's present only without fixation. If when you do that, the nystagmus intensity, when you remove fixation, the nystagmus intensity doesn't increase by that significant amount, then you consider that nystagmus that's present only with fixation. So following that rule should fairly be make it easy to identify whether it's a central type of nystagmus or non-localizing type of nystagmus. Again, I want to spend a few minutes to justify why we do these rules. It's understanding it makes it easier to actually figure out the rest of the test, and I'll come back to that and talk about the pathophysiology a little bit. So this is the typical spontaneous nystagmus. I'm going to play the video. You see that the patient's fast beats are to the patient's right, which, as you know, it's always patient's right or left that's designated for the direction of nystagmus, when we usually use the direction of the fast phases as to designate the nystagmus by using the word beat. When we say right beating, that means fast phases are to the right. This is a little bit unfortunate because actually the nystagmus is generated by its slow phases. If you don't have a slow phase of nystagmus, you'll never have fast phases. but that's typically what we've used historically, and we use the fast phases as an identifying for direction. So the type of spontaneous nystagmus that's typical, it's a conjugate eye movement, so both right and left eyes will move at same rate, same pattern. The nystagmus slow phases are typically linear. Those of you who have listened to the first webinar, you realize that that's not always the case, especially for central or congenital nystagmus. The slow phase of nystagmus may be different shapes than a line. When nystagmus is really strong, you can see it both with and without fixation, but typically with fixation the intensity would be very low, and at least by a factor of 2 lower than the nystagmus without fixation. So how's this nystagmus generated? What's the significance of this nystagmus? So here you see a schematic diagram of the person's eye movements and the configuration of the vestibular system. So you have the right labyrinth, left labyrinth. The information from the canals are carried through the vestibular nerve. So you see the vestibular nerve activity here. This information goes to the vestibular nuclei, and under normal circumstances you have these secondary vestibular neurons that are very similar in nature to the primary vestibular neurons in the vestibular nerve, and under normal circumstances all they do is just relay the information. The only time they start intervening when there's something not right. So as long as everything is going the way we expect it to, the secondary vestibular neurons are just a relay station. So what happens when you have a patient's head at rest? Our vestibular system, our 3 semicircular canals, they act like a 3-dimensional scales, like the scales of justice. Scales of justice. So if you move your head, the scale moves up and down, and the fact is that they always tie the right and left scales are tied to each other, so when one moves up, the other side moves down. So here it is that at rest you have both sides of the scale basically equal. That means the neural firing from the right and left side are equal. This tells our brain that nothing is moving and the head is at rest. So if you move your head to the left, let's say you move it 30 degrees per second, or something like that, it doesn't really matter. But when you do that, what happens that the neural firing on the leading ear, in this case the left ear, it increases. That's so the one side of the scale goes up or down, and the other side does the opposite. So in this case, the right side, the neural firing at the vestibular nuclei level, this gets reduced, and then the imbalance of the scale, you have higher neural firing here and lower neural firing here. That signals to the brain that the head is moving to the left, and the vestibular ocular reflex job is to move your eyes slowly in the opposite direction to match the head velocity. Once your eye hits the orbital limit, then the fast phase of nystagmus will bring your eyes back to the center, so you get nystagmus. So if I'm moving the head to the left, I'll get left beating nystagmus. If you measure the slow phase velocity of this nystagmus, at least at the onset of the rotation, this slow phase velocity will match the head velocity in the opposite direction. So the slow phase velocity would be 30 degrees per second to the right. So one thing I did forget to mention is that the neural firing, both the right and left at rest, they're not zero. The scale is always pushed up, so you have something like if you take one of these hair cells or one of these nerve strands and record the activity, there's about 100 spikes per second. It changes depending on the which nerve cell you're looking at, which hair cells you're looking at, but generally on the average about somewhere between 70 to 100 spikes per second. So that's the at rest. So whenever you move your head one direction or the other, you have the ability to go higher than that or lower than that. So the important message from this is that the slow phase velocity of this nystagmus mimics the head velocity in the opposite direction. So what happens if you have a loss of vestibular function? You can have it in the semicircular canals, you can have it in the vestibular nerve, or you can even have it in the secondary vestibular neurons in the vestibular nuclei. So when that happens, immediately after that loss, you will have the nystagmus, you will have the neural activity drop. In this case, let's assume it's a full complete loss. In this case, the neural firing, that tonic neural firing, that steady state neural firing, suddenly drops to 0, but on the intact side you still have the same tonic activity of 100 spikes per second. This actually tells the brain as if the head is moving to the left. And how fast is the head moving? Well, it's depending on what the difference is. If this is 100 spikes per second difference, and in our daily life we've learned that 100 spikes per second means 30 degrees per second of head movements, that's how fast the patient perceives the head movements to be. So this asymmetry causes what mimics exactly the type of nystagmus we get when we move the head to the left. This is spontaneous nystagmus. So the intensity of the spontaneous nystagmus tells you what the patient is perceiving as the head velocity. So it's not that difficult to figure out that if the patient has a 40 degrees per second of spontaneous nystagmus without fixation, that means the patient feels like their head is moving 40 degrees per second. That patient is quite symptomatic. Once the nystagmus is 5 degrees or 10 degrees, that intensity is reduced. So what we are showing here is immediately after the onset of the lesion, but if you wait a few days, the compensation mechanism, which we won't have to go through that today, maybe that would be a topic for another webinar. The compensation mechanism, what it does, it tries to rebalance the scale that I was talking about when the head is not moving. As you might imagine, that reduces the symptoms, and that actually helps the patient deal with their symptoms. So over the course of the few days or few weeks, that's what the central nervous system does. It starts pumping neural activity in the central nervous system on the side of the lesion, so it would look like there's more neural activity. So eventually, once this happens, the patient's static symptoms, spontaneous nystagmus, will be reduced to a level that's manageable. The patient may not have as much symptoms. So there are key factors here. What happens is that nystagmus, once this compensation is occurring, typically we expect the nystagmus to disappear, but in reality it really never completely disappears. And there's a reason for that. The reason for it is that as long as the patient perceives the asymmetry to be motion, then the compensation can proceed. Once the patient stops perceiving the asymmetry as movement, then there's no need to compensate. So let me give you an example. So if you were putting a patient in a complete darkness and you start rotating the patient very slowly, the patient will make a 360-degree rotation, and let's say that takes 2 minutes. For most of us, some people might have perception of that motion, but most of us, if you don't get any tactile information, if you don't get any auditory cues or visual cues, that type of motion is subthreshold to our motion detection. So after that 2 minutes, or during the 2 minutes, if you ask most people, do you feel like you're moving? Most of them will say no. So that 2 minutes is equivalent of generating something like a 3 degrees per second of nystagmus. If you were trying to get the 4 degrees per second of nystagmus, that will be equivalent of making the same motion and going through that in 90 seconds. So there's a good physiologic reason why we have limits for normative values. Sometimes people become concerned that how can any type of nystagmus be normal? Well, with fixation that is true, but without fixation, if the patient doesn't perceive that level of nystagmus as meaning motion, then there's no reason to fix that. And that's why we have these limits. And I mentioned some of those values at the beginning. Most of those were based on statistical analysis, and as you know, based on the sample, based on whether the patient has had any previous lesion, or even lesions that may not have created any type of obvious symptoms. So the values can go a little bit higher, a little bit lower. But when you go from a physiologic point of view and you look at the perceptual values of the vestibular system, that 4 degrees per second is really a good number. Aside from the statistics, which also confirm the 4 degrees per second, from a perceptual point of view, the limit of 4 degrees per second seems to be a good number for spontaneous nystagmus without fixation. So one of the things that will occur with spontaneous nystagmus is that if you ask the patient to look at the fast phases, direction of the fast phases, the nystagmus is actually stronger. So, for example, here, when the patient looks to the right, this patient has a spontaneous, left-beating spontaneous nystagmus. And this is with fixation, obviously. When the patient looks to the right, the nystagmus is not present. You cannot detect it. On the other hand, when the patient looks to the left, there's obviously a perceptible level of spontaneous nystagmus or gaze nystagmus that you can see. This is called Alexander's law. And originally, this has been thought that the nystagmus that fits Alexander's law, it means it's peripheral. That's not entirely true. There have been at least 2 publications that show that even central type of nystagmus might present with Alexander's law. But as I said, spontaneous nystagmus is so prevalent in peripheral nystagmus that if you take a random sample, most of them are going to be peripheral patients anyway. So in the case of this type of nystagmus, if you remove fixation, in other words, you close your goggles, the nystagmus becomes much larger. So this distinguishes that from a central type of nystagmus that would have been present in the gaze test. But if this was central, then the nystagmus will not increase significantly. So this is a sign that this is a non-localizing nystagmus. For those of you who might wonder, what's the origin of the spontaneous nystagmus? I'm sorry, what's the origin of Alexander's law? It's not quite clear. There are several different reasons for it. But if you just intuitively think about it, we have what's called endpoint nystagmus that we discussed before. So if you move your head, your eyes way far to the one side or the other, you get this mild nystagmus. Now imagine if you add a steady state nystagmus to it. When you look at the direction of the fast phases, that endpoint nystagmus gets added to the steady state nystagmus. When you look away from it, the steady state nystagmus, the endpoint nystagmus gets subtracted. So what you're seeing here is probably some combination of endpoint nystagmus and spontaneous nystagmus, and that's what the origin of Alexander's law is. So this is now, I'm going to show here something that doesn't look like a typical nystagmus. So first of all, look here. I'm going to stop this one. You can see torsional eye movements. You can see upbeat eye movements. Torsion is toward the patient's left, or in this case would be clockwise. You also see upbeat nystagmus, and you see a little bit of a left-beat nystagmus that would become very obvious in the left gaze. So that follows Alexander's law. If you remove fixation, then all those nystagmus, except for the torsional nystagmus, the amplitude of them becomes much higher, the intensity of them becomes much higher. So this is the type of nystagmus that's left-beating horizontal nystagmus. It's strongest in the left gaze, up-beating nystagmus, and you have torsional nystagmus beating toward the left ear. It's clockwise. So you may not recognize this, but this is actually a spontaneous nystagmus. What is the origin of the nystagmus like this? So let's just review what I said before. I kind of skipped through some of the complexities. I just looked at the horizontal nystagmus, but in fact, spontaneous nystagmus might be both horizontal, vertical, and torsional. So why is that? So if I could generate focal lesions in different parts of the labyrinth, if I damage the lateral semicircular canal, let's assume on the right side here, this will generate horizontal nystagmus just like the patient's head was moving toward the left in the plane of the semicircular canal. So you get nystagmus that's horizontal, beating toward the intact ear, and slow phase toward the damaged ear. So you'll have left beating nystagmus. If I could damage the anterior canal, focal lesion in the anterior canal, now you will get eye movements that are both vertical and torsional. So on the vertical component, you get the fast phases moving upward because this patient feels like their head is moving downward. So the opposite of that would be upbeat nystagmus. The patient also has torsional nystagmus with the fast phases moving away from the damaged side, just like the horizontal nystagmus. So in this case, the patient will have upbeating and torsional nystagmus. So if we damage the posterior canal, the opposite of that will happen. You'll have the downbeat nystagmus because the patient feels like their head is moving upward, and the torsional nystagmus will have the same direction. In other words, the fast phases will be away from the damaged ear. The reason that you see a little bit of a different orientation for where this, whether it's upbeat or torsional, the eyes actually during this process move disconjugately. So, for example, for posterior canal, the vertical nystagmus is more obvious in the contralateral eye. The torsional nystagmus is more obvious in the ipsilateral, and the opposite is true for anterior canal lesions. So if you have damage to the superior portion of the vestibular nerve or inferior portion of the vestibular nerve, it combines the focal lesions from the pathways that are involved. So for example, if for superior portion of the vestibular nerve damage, you get horizontal nystagmus beating away from the site of the lesion, you get upbeating nystagmus, and you also get torsional nystagmus beating away from the site of the lesion. The otolytic effect is also a torsion of the eye, static torsion of the eye, but I'm not going to talk about that right now. So if you have an inferior portion of the vestibular nerve damage, now you have downbeat nystagmus along with the torsion away from the site of the lesion. So, and then finally, if you have combined all of these both the superior and inferior portion of the vestibular nerve, if they're damaged, now you will have nystagmus, or combination of all three semicircular canal lesions, the focal lesions that we discussed. One important factor for damage of the entire labyrinth or both portions of the vestibular nerve is that the vertical components from the posterior and anterior canals, they oppose each other and they cancel each other out. So generally you don't see vertical nystagmus in total damage to the labyrinth. This is the origin of, historically, you've heard that the vestibular nystagmus has to be horizontal or horizontal torsional. As you saw just a moment ago, that's not true. You can have vertical and torsional component. So a better way of expressing this is that if you have a purely vertical or purely torsional nystagmus, then generally that is not that's not peripheral. But I have to warn you, the interpretation is not actually easy. It's complicated because the compensation occurs in different stages. So, for example, the torsional nystagmus compensation occurs much faster than vertical, and the vertical happens much faster than the horizontal. So if you waited 2 or 3 weeks and you see the patient only with horizontal nystagmus, you don't necessarily know if the damage is to superior portion or inferior portion, or so this is just a repeat of the slide that I wanted to summarize everything here. So you have the conjugate eye movements for spontaneous nystagmus, slow component, linear slow component, and the difference between fixation and without fixation. Usually the nystagmus has to be much stronger without fixation, and it follows Alexander's law. Nystagmus is usually horizontal, but it can have vertical and torsional components if the lesion is a focal lesion of vertical canals or their pathways. All right, so now we generally, when we talk about static position testing, it's a manifestation of spontaneous nystagmus. There are few exceptions, but most of the time what we're seeing in the position testing is the spontaneous nystagmus. So generally, when we look at the static position testing, the nystagmus intensity can vary from one head position to another. So we don't usually get, in the sitting supine head right, head left, all the nystagmus being 6 degrees per second. Generally, it's different. It's one is 5 degrees, one is 10 degrees, one might be 8 degrees. That's usually referred to as positional nystagmus because the intensities change. Well, why does it change? Well, one of the main reasons is gaze direction. Intensity of nystagmus, as you saw in Alexander's law, it changes in different directions, in the gaze directions, and we don't control for the gaze direction during these tests. We don't tell the patient look certain way or during these tests. So that might be one reason. It could be related to the level of alertness. But one feature of the position test is that nystagmus actually can be different directions in different head positions. So you have the variations of geotropic and agiotropic nystagmus. The nystagmus, if it changes in a single head position or a single gaze position, if the direction changes in that case, that's not a spontaneous nystagmus. We discussed that in detail last time. But geotropic and agiotropic nystagmus are variations of spontaneous nystagmus. That doesn't quite match the physiology, so we should ask a question: why is it that the direction of nystagmus can change in different head position and still be considered a variation of spontaneous nystagmus? Well, there are a couple reasons. One is that when you move the head, we are assuming that these semicircular canals are completely planar and exactly in a certain plane that we assume you're moving the head in. That's usually not the case. These canals are not quite a flat presentation as we think about. So it's possible in different head orientations we get a little bit of a gravity effect. It's also, this might be coming as a modulation from the otolith organs. We know the otoliths are sensitive to gravity, so they might be modulating the responses of the canals. There's also another possibility. We know, or we assume, that the specific gravity of the cupula and the endolymph is exactly the same. That's why semicircular canals are not sensitive to gravity. But there might be some room for variation here. There might be a little bit of a difference between that. So the canals might be slightly sensitive to gravity. So that might be the origin of agiotropic or geotropic nystagmus. That's kind of like what we talk about in certain types of BPPV, intractable BPPVs, where we think that the patient might have something other than BPPV, like what's called a heavy cupula or light cupula or something like that, where there's a metabolic change that affects the cupula or the endolymph and causes steady state nystagmus. That probably is, we should not consider that a variation of spontaneous nystagmus. That's something else. So these are some examples of spontaneous nystagmus manifestation in the static position testing. This is a nystagmus that has different intensities in different head positions, and at least in one head position it exceeds 4 degrees per second. 4 degrees per second, that's considered abnormal. But the directions are all the same in this case. The variation of that is, this is the patient who has left beating nystagmus, but also has a geotropic effect of the head position. So when the head is turned right, the nystagmus becomes right beating, and when the patient's head is turned left, it becomes left beating. Now, in cases like this, you have to separate that from transient nystagmus. So in this case, this nystagmus was not transient, so it's not a BPPV type nystagmus that's caused by lateral canal abnormality. So this is a steady state nystagmus. Another variation is the agiotropic nystagmus, that is in this case, in the head right position, the nystagmus beating left, and in the head left position, the nystagmus is beating right. Again, the origin of this, we're not exactly sure, but again, you have to separate this from a more transient type of nystagmus that occurs in the cupulatitis of lateral canal. So what's the localization? As I mentioned before, if you're just looking at it as an isolated case, you have to consider that non-localizing, because it could involve the peripheral or central vestibular pathways. Generally, if you have a caloric test that goes along with the findings, that could make it a more localizing finding. This is an example of the patient who has nystagmus that's only present in the head left and head right positions. Not much of it is present in the supine position. And the question is this a neck effect or not? So in this case, when the body is turned left or the body is turned right, the nystagmus intensity doesn't change at all. So in this case, this is not a neck effect. The most likely cause of something like this is some form of a, in this case, it's not a alcohol ingestion, or if it is an alcohol ingestion, it's immediately after alcohol ingestion. It's some sort of substance that the patient has taken that might affect the specific gravity of the cupula or the endolymph, and it causes this kind of gravity specific type of nystagmus. So just quickly to finish our topic here is that one thing I have not talked about is spontaneous vertical nystagmus. So vertical nystagmus that fits all of the definitions for spontaneous nystagmus we talked about, except that it's in the vertical plane. So here is an example of it. This patient has upbeating nystagmus without fixation. If you give the patient fixation, the nystagmus completely disappears. So how should we interpret this? Well, again, I think there's been very few studies in these cases, and it looks like actually upbeat nystagmus is quite prevalent in many people who are asymptomatic. A study that several years ago we did, we looked at the 40 normal individuals, and the limit we came up with was 7 degrees per second. I've always been told that, well, maybe we just had too many drunk college students. I can assure you, at least to the best of our knowledge, we tried to exclude them. But this is the number we came up with. I'm hoping that other people will repeat this, because it does look a little bit of a high number to me. But one of the things you have to make sure is that there's no crosstalk. Sometimes if your goggles are tilted, the nystagmus that shows up in the horizontal channel may get reflected in the vertical channel without actually having a nystagmus. So you just have to make sure that you're not having crosstalk. And that's easy to do. Just have the patient look horizontally back and forth, and your recording should be limited to the horizontal channel. If you see a simultaneous synchronous movement on the vertical channel, then you have crosstalk. So at any rate, just to summarize, if you have vertical nystagmus with fixation, then that's a central abnormality. It's always, there's no other number that you have to consider. But if you have vertical nystagmus without fixation, you do need to measure the slow phase velocity. And right now I use 7 degrees per second, but until somebody else does a better study on that. My clinical observation has been that the vertical nystagmus is quite common in patients who have motion sensitivity syndrome or migraine-associated dizziness. Again, that's an anecdotal observation. I don't have any study to back that up. So just summarize our talk. This is a flow chart of how to go about interpreting the horizontal nystagmus. And if you remember from last time, always break down the nystagmus to its primary components and interpret each one separately. So if you have a nystagmus that's present with fixation, this is what you get from the gaze test. If you have it and the intensity of it doesn't increase by more than a factor of 2, then that's a central finding. If the increase is more than a factor of 2, then it comes back to the same type of nystagmus that's present without fixation, and this you usually pick that up in the static position testing. Then you ask your question, is it in a single gaze or single head position? Then it's a central one. If not, then you compare it with a threshold. If it's less than that threshold, then it's within normal limits. If not, it's a non-localizing finding. And then finally, vertical nystagmus, almost the same kind of thing. It's present with fixation, it's central. If not, then check with the limit. If it's lower than the limit, it's within normal limits. If not, it's abnormal. One distinction between vertical and horizontal nystagmus, even if it's higher than that threshold and you consider it abnormal, we don't really know what the clinical significance of that is. We don't know what the origin of it is. That's different than non-localizing or peripheral or central. We just don't know where it's coming from. And I usually state that the clinical significance of the finding is unknown. All right, thank you very much, and I'm happy to take questions.
So thank you very much, Dr. Barine. That was a really insightful webinar. We actually have one question which has already popped up, and it relates to the study which you did looking at vertical nystagmus. And the question says, was that study ever published, which showed 7 degrees per second as significant?
No, unfortunately, we have not published that, but I do have abstracts and a brief description of the studies in 2 or 3 different settings that they were presented. If anybody is interested, I'll be happy to send the PDF of the slides for that presentation so you know exactly what we did.
That's great. Thank you very much. We have another question which pops through as well. So it says, you mentioned earlier in the presentation that the sitting spontaneous test could count as one of your 4 positions, but in the US, sitting spontaneous is actually considered its own separate test as part of the 92540 code. Then could Hallpike, as a then could hallpikes count as part of your 4 positions requirement since they don't have their own code?
I guess I'm not a code specialist, so I want to qualify my answer. Generally, how I did this in our clinic before, I did the gaze test with right, left, up, and down, and center, which is typically not part of the center, is not part of the specific definition of gaze test. When I did the position testing, then I did the position testing without fixation and sitting, supine, and head right and head left. So then I would take the gaze center test, and I took the sitting position test, and combination of those two, they gave me the spontaneous nystagmus. So I never really actually did the spontaneous nystagmus test according to the definition. So that's how I justified 4 positions for the CPT code. Now, I think in your case, what the question that you've asked is actually, can I use the hallpike? I assume you can. I think if you're recording the eye movements in the sitting position in the hallpike and then proceeding to the head right or head left, you can take that portion of it and assume that that's your sitting position. But I don't think this has been a big issue any place, and I think if you're not sure that you're fulfilling the requirements of CPT, well, you can always do body right and body left, and that will give you 2 additional position. I think I successfully dodged that question. Okay.
Thank you very much, Cameron. One question which you alluded to at the beginning of the talk was about the mental alerting which is required and the different types and which ones are best. I was wondering if you could just spend a couple of seconds elaborating on that whilst we're in this section of the webinar.
Okay. Yes, thanks. Well, actually, most everybody knows that we alert during the tests that are done without fixation. And generally, if we ask why do we do this, well, the answer is that we suppress nystagmus. Well, then the answer is, why do we suppress nystagmus? That's if we don't have a target, how do we suppress nystagmus? Well, this became more of an issue because when VNG came about, people said, well, you don't have to alert, and the justification was that, well, the reason we alerted in ENG was what's called the Bell's phenomena, where your eyes actually move up in the socket, and so the alerting was to prevent that, so you could see the nystagmus. This is actually not a valid assumption. I always give the example of patients who are comatose. There's a test that most of you might be familiar with. Either it's called a doll's eyes test, and then a variation of that is called the ice water test. A patient is comatose. In order to figure out whether the patient has is brain dead or not, generally you move the head and you look at you lift the eyelid and you look at the patient's eyes. If the eyes move in the opposite direction of the head motion, then the patient has brainstem function and they're not brain dead. If the eyes are tied to the head and they do not move, that means usually there's no vestibular ocular reflex. And the variation of that is you put ice water in the ear and you lift the eyelid and see if the eyes move toward the ice water ear. Again, same thing to make sure that the patient has vestibular ocular reflex. So you can't get much more on alert than a comatose patient, right? So in a comatose patient, you actually have the VOR function. So this assumption that we do the alerting so the patient doesn't suppress eye movements, that's not correct. What happens is that the VOR is functioning, whether you're with fixation or without fixation. What is necessary to see the nystagmus is the fast phase of nystagmus. So in a comatose patient, you don't ever see nystagmus. You see the slow phase of the eye movement. The same thing in a patient who's is not quite alert. the eyes move to one side and they get stuck there. As soon as you say something, their cortical function returns, and you get the fast phase of nystagmus, so you see it. So in these cases, the vestibular ocular reflex is functioning. It's the fast phases that you need to generate to see the nystagmus. So that was a long explanation, but I thought it was necessary to see why we do this and when we should stop doing it. So how do we do this? If you have a target, if you have fixation, you never need to do any alerting, because you already have the patient looking at a target. There's no possibility that the eyes are going to drift to one side. So you only do this in the absence of fixation. So what's the best method? Usually it has to be a moderate level of challenge to the patient. So if you have really easy questions, count by one or count by two backwards, some patients, that is not alerting enough. So generally the best type of questions will be memory recall with moderate level of challenge. But if you see a robust nystagmus, you don't have to be a drill sergeant. If the patient has a robust nystagmus, they're alert. So you can just carry on a conversation, and that will be fine. On a patient, especially those who've had head injuries, they're much harder to keep alert. In that case, you have to be a drill sergeant. You have to be going through questions ahead of time in your mind and not give long pauses, because the nystagmus will disappear. So memory recall positions like give me boy's name with letter A, give me color's name by letter D, or stuff like that, something that the patient has to use their memory recall.
That's great. Thank you very much. So we don't have any more questions in at the minute. I'll just give people the opportunity to type for just a couple more minutes. So as I mentioned before, if you're not familiar, there's a message tab at the bottom of the screen. In the meantime, I'd just like to highlight that we have several other webinar sessions running throughout the year. On the 23rd of October will be our next webinar session, which will cover OVEMPs by Dr. Mike Maslin. On the 8th of November, we've got Integrating Diagnostic and Functional Tests of Dizziness and Balance by Darren Whelan. And in the 13th of December, we've got Tests Beyond the Audiogram that can influence hearing aid feature selection, and that's by myself, Lee Martin. So I see that there is still no activity remaining in this instant messaging box, so I guess that will conclude today's webinar. If anyone has any additional questions after, then please email academy@interacoustics.com, and we can certainly look at answering those questions for you, or if we can't answer them, then we can forward them on to Dr. Barine. So that just leaves me to say thank you very much for participating, and hopefully see you at the next webinars. Thank you very much. Bye-bye.
Thank you, Lee. Thank you, everyone.
Thank you.